All right. Wow, my voice is loud. Good afternoon, everyone. Thank you for taking the time to join us. Today we're going to be discussing about health equity, data, and technology as a whole. I've got some wonderful guests on the panel and somebody who will be joining us via Zoom. And I'll start by introducing myself, and I'll give each of the panel members a chance to introduce themselves. So my name is Malone Mukwende. I'm the founder of a company called Black and Brown Skin, and we're on a mission to create a world where Black and brown people don't have their health compromised simply due to the color of their skin. At the moment, we are building a database, which will be a database of insights on darker skin. So that's symptoms, treatments, pictures of their skin conditions, and a whole lot more. And I will pass on to Matt to introduce himself as well.
Sure, I'm Matt Might. I'm presently the director of the Precision Medicine Institute at UAB, which is in the other Birmingham, Alabama. And I've had sort of a full career pivot in my life, starting off as an academic computer scientist, ending up in academic medicine.
Awesome. Hi, my name is Sara Khalid. I'm a senior research fellow in biomedical data science and health informatics at the University of Oxford. I lead a group called Planetary Health Informatics, which is essentially about taking big data, artificial intelligence to crack global health challenges that involve inequity oftentimes. Nice to meet everyone.
I'm Emma. I'm a professor of computer science and by courtesy of basically public health at Cornell University. And I'm joining from the East Coast of the United States. It's nice to see you all. And my research broadly applies machine learning and data science methods to study healthcare broadly and health inequity specifically.
Okay, great. So I think we'll start with you, Emma. So just to give a bit of context and a bit of baseline for what we're going to be talking about today, could you possibly define what a data-driven approach is to healthcare?
Sure. Yeah. I mean, I think depending on who exactly you're talking to, they might define that slightly differently. But broadly, I think it means, using data sets and statistical methodologies to try to accomplish tasks we'd like to accomplish in healthcare. So that might be something like, identify the people who are likeliest to be testing positive for COVID, or predict from a patient's mammogram whether or not they have breast cancer, or design a predictor of 10-year cardiovascular disease risk. But a common element to all of these approaches is, you combine some data set with, an outcome you're trying to predict, or something you'd like to understand about the patient's health state, and you're trying to sort of learn the relationship between these things in a statistical way, as opposed to, for example, the doctor just being like, I feel like this guy might be sick.
Yeah, that's interesting. I think it's, for me, one thing that was always of interest is the fact that we can have all of these statistical models, all of these doctors and professors who have learnt the body extensively, but we still have some gaps and some almost like pit holes. And I wanted to find out from you, both Matt and Sarah, what are some of the causes of inequitable outcomes from these data sets that we're collecting?
Yeah, I guess I'll take the first pass at that. Yeah, so inequities leak in from many different directions. I mean, there's the biases of human physicians. There's the biases encoded in data sets used to train models that are then used to treat. There can be biases encoded in algorithms even without machine learning use. There's lots of ways that bias can creep into and cause inequities. There's inequities in and I'll just sort of a laundry list here, in the lack of representation of different groups in the data sets. So in clinical trial data sets and large population study data sets, not having an appropriate representation for different groups leads to all sorts of inherent inequities and biases when those data sets are then applied at the point of care.
Mm-hmm.
Yeah, absolutely. And I think there was a latest Oxfam report that says 1 in every 4 seconds there is a death that has health inequity as one of the contributing factors. And inequity is not something that is quite cross-cutting as well, across a different number of social determinants that include, they're not limited to ethnicity or race or age or gender, but I mean, nowadays we even have climate inequity as well. So in some of the work that we've been looking at more recently, since the COVID pandemic, it has been about kind of trying to see, with the context of data-driven approaches, there's a plethora of data that are being collected, nowadays, terabytes of data coming in every single day. If you think of just real world data that are routinely collected in healthcare systems like GP practices or hospitals or registries and claims and so on, I mean, how can we use that to address some of the inequities? What we've started to see is that in order to even be able to kind of start tackling the issue of algorithmic biases or even data-driven biases, we need to maybe start right at the start, which means in some of the work we've done is that to start looking at, when we talk about even ethnicity information, what sort of ethnicity information exists in data that have been captured already. And we find, at least in the UK healthcare setting, which is representative of surprisingly no less than over 100 different ethnicity concepts, if you look at in terms of data, that yet at least a third of patients who go to their healthcare providers are missing self-reported ethnicity information. So that's where the gaps even start. Now those that missingness or incompleteness is one thing, but even for those who do have ethnicity information recorded, there can be inaccuracies. A single person may not self-identify with the same ethnicity over a course of their lifetime. So, you have a case of multiple ethnicity records for the same individual as well. And I mean, it's a lot to unpick. But, and so there are lots of challenges around the issues of ethnicity that has been captured. And what the space we're working in or have been working in is to try and at least start at the very start, clean the data that are available, make those available to researchers, which is a starting point. So in the UK trusted research environment data sets, which are pulling data from NHS Digital, the National Healthcare Services, we now know that there are, when we've been fortunate enough to be able to work with ethnicity records from over 60 million individuals in the UK, which is predominantly unprecedented if you look at ethnicity research in the world globally. And we've been able to kind of delve into ethnicity beyond your high-level buckets of, let's say, ethnicity group: white, black, Asian, other, right? And go further deep and to see that there are other ethnicity groups that people self-identify with. But that's just the starting point when it comes to looking at ethnicity, and ethnicity again is just one way inequity is playing out.
Mm-hmm. I think that's very interesting, especially around the ethnicity data not being captured. I just wanted to kind of follow up on that point. Do you think the problem is the data not being reported from the patient's perspective, or the data not being collected from the healthcare provider's perspective?
Yeah, so I think again, speaking from the UK public healthcare system perspective, I think it's a combination of both, and where some of the work we've been doing has also involved discussions with members of the public and patient representatives, and some surprise from the patient's point of view has been expressed when they've been told that there's all of these gaps in your data basically, because as far as patients are concerned, when they go to the GP for the first time, they are asked a bunch of questions and they answer a bunch of questions. Problems start to come in because different healthcare providers are asking different sorts of information. So there is that issue of standardization, lack of standardization and data harmonization when patients are asked information. We've also seen that there are patient profiles or patient groups that are reluctant to offer or volunteer information. We also found that when provided with sufficient justification for the need, why are we asking for ethnicity information, or how might it help in doing better research that will ultimately improve your own health care, patients are very willing to be able to divulge that information. But if the same information is being asked by claims for claims purposes or financial purposes, then people process differently which information they want to divulge or not. And I think just finally as well, there's unfortunately lots of assumptions as well made from the healthcare provider's perspective as well, where case studies have shown that when patients walk into the room, it's either the patient self-identifying their ethnicity, or it is being assumed on their behalf by their healthcare provider. So there's a lot of, there's a mixed, it's a mixed space out there, but certainly one that where there is a good case to be made for the better the data is at the point of source, which is the point of collection, the better it works downstream all the way through to algorithmic analysis and doing research with that data as well.
That's something which, when solving any problem, it's almost always better if we can solve the problem right from the source as opposed to trying to solve it halfway down the river. One thing you touched upon, and now just heading over to Matt and Emma as well, I think I'll start with Emma. Sara mentioned about how standardization is often an issue, and from a UK perspective, in some respects, we could argue that we're lucky because there is a National Health Service, and to a particular extent, everyone's healthcare data is standardized through our health service. But I understand in the US, there is a lot of different providers. There's almost like geographical lottery depending on where you are, and almost a lack of standards, which is creating a lot of pitfalls. So Emma, I just wanted to find out about this standardization. How do you think it affects the data collection that is going on in the USA at the moment?
Oh, I think it's a huge problem. I did just want to echo Sarah's points, by the way, about how race data. This is true in the United States as well. Like there's tons of missing data. There's race data being collected in very coarse fashion. That's grouping together subgroups that should not be grouped together. There's huge missingness. There's patients who don't want to report. So it's an enormous problem here as well. The lack of data standardization. Yeah, I mean, it's funny. I was in the UK a few months back, and I had to go to a clinic for a minor thing, and they were like, "Oh, you're in our systems still from 8 years ago when I had been studying in Oxford," and I was like, "Wow, like you guys, this is much better than in the United States, where like they often cannot find me if I go to like a clinic like 3 miles away, right?" And I think in the United States it has real consequences for patient care. Even for example, like getting like medical scans like from a clinic in California to a clinic in New York can be an ordeal, and that's something that like foreseeably, it has real consequences for patient care. For example, if your doctor in New York is like, "There's a suspicious blip on this scan, can you get us your scans from California so that we can compare?" That's a challenging task, which often falls on the patient. If you're a patient who already has disparities in access and, is working 2 jobs and has a million things to worry about, you may not have the bandwidth to like call the clinic again and again and again to get the scan from one place to another. So, and so then, the thing doesn't get followed up on. And so I think that's a real thing, which, foreseeably harms patient outcomes. It also harms, medical studies, right? It means that it makes it harder to do multi-site studies where you like compare data across multiple sites, which is like critical to ensuring that, for example, AI or machine learning algorithms generalize from one hospital to another. That's like a massive problem in medical machine learning. It means that like you may do some studies on highly non-representative patient subgroups because you're only looking at one hospital because that's all you could get the data for. So I think the problems here are severe, and I do think people are increasingly recognizing this and trying to create sort of broader data sets to enable better AI, whether that's sort of private actors like individual hospitals trying to anonymize their data so they can make it essentially publicly available, or sort of government institutions like the NIH or whatever trying to create these sort of larger data sets which are linked to people across the country. But it remains a huge problem here, and it very much both harms immediate patient care, but also medical machine learning and data-driven approaches.
It's almost as if the current biases that exist in the world today will only be exacerbated a lot further with the advancement of technology. And one thing that has been kind of touched upon by the 3 of you since we started is having this representation across our data. And Matt, I know you have traveled all the way from Alabama in the USA, and Alabama is in the global south of the USA. What is the issues with representation when it comes to people in the global south?
Yeah, so within Alabama, we have relative to the rest of the country, a very large African American population, and also disproportionately poor. And historically low rates of enrollment in any kind of clinical study whatsoever. And this means that when the data that we generate to actually apply point of care is used, it's not coming from a representative group. So Alabama, recognizing this problem years ago, has had initiatives, statewide initiatives, trying to reconcile the inequity and just the representation at the level of data generation. Not to mention also all the issues we have with disparate medical records. Within the city of Birmingham, I have 4 different medical records at 4 different providers, and they don't talk to each other. And the same is true for essentially everybody across the entire state. So we've created things like the Alabama Genomic Health Initiative, which is a statewide initiative to help enroll everybody at the respective proportion within the population. So we have, a benchmark genomic data set that works for folks within our state. So we can at least start addressing, the issues with genomic inequities, which are certainly there. But that's sort of the tip of the iceberg when it comes to the inequities that we're dealing with in Alabama.
Mm-hmm. And I think genomic inequity is something which is also a massive problem in the UK. In my experience from speaking with people who have worked in organizations such as Genomics England and on the UK Biobank project, a lot of them do report that the data that we have in the UK Biobank, for instance, reportedly less than 5% of that data comes from people of diverse backgrounds. And that's almost like the precedence of a lot of our future medical discoveries. You mentioned about how people are not essentially engaging with healthcare. And if they're not engaging, we're struggling to collect data from them. How can we, on a population level, like if we were to go out into the streets of London, for instance, how can we get more people to engage with this type of stuff?
Yeah, so I don't know if these will translate exactly to the streets of London, but we have found techniques that are specific to Alabama. And I think that's really what this is all about, is you have to find the community structures that are unique to every neighborhood, to every community, to really figure out where is trust. Because I think you have to start with who controls trust for individual communities. In the case of Alabama and sort of the American South, one thing we found is that African American church leaders were in these positions of trust, and that by working with them, we could actually significantly increase rates of enrollment in clinical trials and population health studies. And the other place, oddly enough, is barbershops. So barbershops they're actually pillars within the African American community. And by engaging and going and doing outreach at that level, you can significantly increase enrollment in studies. And also, it's a chance to have conversations that overturn narratives and acknowledge historical wrongs that we're committed in the state of Alabama when it comes to biomedical research. But it really comes down to the level of individual conversations to really address it.
And just correct me if I'm wrong, but was the Tuskegee syphilis experiment?
That was Alabama.
Yeah. So, I think that is specifically a place where probably the mistrust in the community is probably stronger than most places in the world.
It is. It's very, even generations later, that mistrust is still there. And it is the kind of thing that has to be healed one conversation at a time.
Yeah, couldn't agree more with that. And I think the power of community cannot be, overstated. And so, for example, a case study that we did showed that, ladies with gestational diabetes, when they were informed of the importance of, for example, their healthcare provider knowing their ethnicity, for example, or racial background, and its role in, because certain, ethnicities are at a higher risk of developing gestational diabetes, for example, during pregnancy. When patients are informed about the importance of certain data being collected for the sake of their own and their future generations' healthcare and that of their community, people are sort of conducive and supportive of the idea of volunteering information as well. So, and all of this happens when you go out in the community through either directly or via community representatives in the appropriate hotspots or hubs.
It almost feels like just almost over communicating is what is needed to get groups of people who don't trust the systems that are in place to be able to actually help us to improve medicine going forwards. I wanted to kind of change direction a little bit and go into a little bit deeper about AI and machine learning and the future. One study that I remember reading last year from Google, Google were working on this device called Dermacyst, I think it's publicly available in the US now. But what DermAssist essentially was, when you go to Google Images, you can take a picture on Google Images of your skin, and it almost uses their Google datasets to backtrack an image that looks similar to your skin. The studies which they carried out this testing of their machine learning algorithms only found that Fitzpatrick skin types 4 to 6, which is anything with melanin, was less than 5% representative in their training of their algorithm. So how can we start to get better machine learning data sets to be able to train algorithms so that we don't have problems like what Google faced in the future? If I start with you, Sara.
Yeah, I think in a nutshell, what at least the mantra in our work or in our group at the Planetary Health Informatics at Oxford is, better data, better models, better care. So it is almost a case of kind of, coming from an engineering background, sort of thinking of it in a way of reverse engineering. So you have to kind of, in order to improve models that are then ultimately less biased, you have to feed them with data that are less biased in the first place to begin with. And there's things you can do within artificial intelligence and machine learning that maybe Emma is better placed to tell us about, such as, for example, there are approaches to kind of deal with the issue of class imbalance, and for instance. However, they have their strengths and limitations there as well, in the sense that maybe, manipulating your training data is something that is useful and not harmful for diagnostics and medical imaging, classification models. But can you use it in the sort of work we do, which is clinical risk prediction? Not really. So we cannot manipulate the data very much at all when we're training it, because it ends up producing either overestimates or underestimates when you apply those models to general population. So the point being that there is things you can do within the framework of the algorithms themselves, such as being kind of rigorous in your analytical approaches and not just relying on one model, but trying on a suite of artificial intelligence techniques and so on. But ultimately, rubbish in, rubbish out. So if you can improve at source, going back to that point, and collect better data that is basically not just sort of ethnically representative, maybe geographically also more representative. So we're involved in this huge effort to try and get regions and countries from the global south to contribute to even COVID analytics during the pandemic, and then from that was useful during the pandemic, but that led us to look at the value of, even when we're doing real world analytics at scale, a lot of the data that is coming is from the northwestern hemisphere in the world. So some efforts, and it takes effort, and it takes building trust and relations with data owners, data custodians, data partners in various settings. So, for example, one of the works that we've been doing recently sounds surprising, but it's the first instance of real-world COVID data that has come from Brazil and Pakistan and has contributed to a large characterization, one of the largest characterizations of COVID-19 across the world. But that's only been made possible because you as researchers care about this issue. You as researchers reach out to the right stakeholders, who then reach out to the people who have the data or are in a position to collect data from the communities. But yeah, that's my perspective. It all comes back to the data.
I think it's just triggered a really interesting thought and a completely random thought. But whilst you were talking, I was thinking about how social media is a massive data churning machine, and we almost feed it so much data every single day. And probably if I ask you, Emma, what role do you think, if any, it's a completely random question, what role do you think social media plays in helping us to get kind of healthcare research and healthcare data at scale?
Yeah, it's a good question. It's not my core area, but it's definitely something that researchers look at. Like, can we use social media as, for example, a surveillance surveillance in the non-creepy sense, as in, for example, like if there's an uptick in people talking about COVID symptoms on Twitter, maybe we can use that as a a measure of COVID activity in that area. I think a general challenge with this, as always, is people who use Twitter are weird, perhaps particularly now in light of what's going on at Twitter, and in general, sort of these issues of non-representativeness are challenging to correct post hoc. I mean, on the sort of broader question of like, how do you get more representative data sets? I think it's certainly better to correct, at the point of data collection than to try to do so post hoc via statistical approaches. Like you can do that, but there are always drawbacks and assumptions one has to make. And I think, it has to be sort of a first order priority of the data collection project. So for example, the All of Us data collection initiative in the United States, is this massive effort to collect data from, I think, 1 million Americans, along with genomic and EHR and social determinants of health data. And they've done a really good job trying to collect a racially representative and socioeconomically representative population. And it's just been a priority in the project from the outset. And, there have been other data collection efforts like that. But I think if you don't sort of focus on that from the very beginning, it will not happen by accident, because sort of inequality and health inequity has a way of sort of affecting it's really incredible how sort of consistently it affects every sort of data collection process at every stage. It's still remarkable to me how consistent it is. The one other thing I would say, by the way, is that we've talked a lot about collecting representative data sets, but I think there are other aspects of collecting good data that don't happen by like automatically. So an example of this is like, it's really important to collect the outcomes you actually care about, and health outcomes can be very challenging to measure well. So like, what does it mean for a patient to be healthy? Can we define this in terms of like objective patient state as opposed to like doctor appraisal of patient state, which could well be biased? That can be a very challenging thing to do, and is very important to do if you want to train algorithms that actually reduce as opposed to increasing disparities.
You mentioned about, Emma touched on the All of Us projects. And Matt, we were actually having a conversation about this ahead of coming into this room. Could you probably give the audience a bit more context behind that project?
Sure. So all of Us, in a weird way, is kind of one of my babies. So I ended up working at the White House for 3 years under President Obama. And the reason he called me there was to help set up, it was called at the time the Precision Medicine Initiative. It morphed into the All of Us program. And it is this attempt to collect the health and genomic records of 1 million Americans. That is representative from the start. In fact, representation was included as a #1 priority for the entire program from the beginning. And it was also out of recognition of the fact that many of the genomic data sets at the time were very unrepresentative, and that it was going to be impossible to bring precision medicine to the scale of the entire country without having that. And so it's actually succeeded. So the last act that President Obama signed before leaving office was 21st Century Cures, and it carried 5 years of funding to get the program going. And it's still around, it's still recruiting, and has essentially succeeded in its goals of capturing representative cohorts. A lot of that's actually happened through my home institution of UAB. We've recruited a very large amount of the underrepresented groups into the program. And it's also been, pioneering not just for the data it's collecting, but in, again, the methodologies used to actually go out and collect that data. So it gives me some hope that, if we actually make it a priority, we can make representation a reality, and the data sets that go in to feed all of this. In fact, as Sarah was speaking, it was occurring to me that we really need a mantra or a rallying cry around, the data that goes in. And if you're a student of history, you may recall the rallying cry for the American Revolution was no taxation without representation. And I think we need a new version, which is no classification without representation. You can't run your prediction, your classifier algorithms, without ensuring at the outset that you have representative data to begin with.
I think that's probably the takeaway message. If you forget anything from this talk, just remember that statement. So if I was to almost put myself into a critic of all of this work on representation, or like to play devil's advocate, someone could say like, well, we have had health systems that have worked for over many years without a lot of representation, and it still is working. So like why is this important? Like why do we need to have a focus on representation for the future? Sarah, if I come to you.
I would argue that have they though, because I mean we have we have innumerable examples of where and this is the stuff that doesn't quite make the headlines, but we know from research, from literature, and actually through the COVID pandemic, this actually did end up making the headlines when, for example, one of the clinical risk prediction tools that was designed to help the government make decisions about who should be shielding and who should get the vaccines first. The algorithm that was used to do that was based on data that if someone's ethnicity was missing, would assume ethnicity to be black. And if someone's body mass index or weight or height status was missing, that was assumed to be that person was assumed to be overweight or obese. And what ended up happening was that over 40,000 young, fit, and healthy black men were asked to come forward and receive their vaccines when they didn't need vaccines. And similar misestimations around women who were pregnant and women in general. So that's just one example. And we've known, historically, tools. There's a tool called Framingham that is used for judging or assessing heart. It's a risk calculator that when you go to your GP, and you're having heart issues or have certain complaints, they're going to use a bunch of information about you, put it into a risk calculator, and bingo, here's your heart health risk. Now that tool and those sorts of many of those sorts of tools have been based on. In this particular case, was based on a group of affluent men from the U.S. Never been challenged, standard clinical practice, at least in the UK. So I would argue that there's a lot of problems, and it's yes, there's a healthcare system that is working, but for the majority maybe, and that's where we need to kind of improve things is to make sure that it works for everyone, not just for most people, but for everyone.
I think even on that point of healthcare systems working for the majority. Interesting statistic that I read the other day is that in the USA by the year 2040, it's expected that people from minority backgrounds today will actually be the majority in the USA. And the implications that this has for like healthcare costs on a bigger level as well. So yeah, it's something that needs to be sorted. I think just to head into another question that I had, we've talked about like representation and other issues within the healthcare system. I wanted to kind of move on to like different tools that we use now within healthcare. You mentioned about some of those risk scales. What are the tools at the moment that we can use to quantify bias, if any, to almost find out if there is bias in the data sets that we're using ahead of time? And if they don't exist, what do these tools need to have in the future?
I guess I can offer my take on this. So it turns out I spend most of my time concerned with rare genetic diseases. And I think this offers us a really unusual opportunity to be very quantified about the nature of bias in the sense that, yes, rare disease is to a certain extent random, except it's very predictable. We should know for almost every group what should be the rate of this disease or that disease, even no matter how rare they are. And that gives us a chance to see, how well is every group represented according to what we predict should be out there in terms of that disease. And right away we find in the U.S. that, for example, African Americans are massively underrepresented for essentially every rare disease. We know that there's all these missing patients that aren't even somehow registering or making contact with the healthcare system, despite the fact that they must have a very severe disease. They're not somehow coming into contact with the system. So right away we know that there's a very measurable problem that we're facing. And so I think in some ways rare genetic disease could be this sort of direct and indirect barometer for the overall level of inequity within the health system as a whole.
Mm-hmm. Yeah, I think it's something which a lot of the time we just have a lot of gaps within the healthcare system. We kind of focus on what is working and kind of forget what's not working. And as we focus more on what's working, we just widen the gap behind us. And moving to you, Emma, what do you think excites you about the future of this space? Like if you were able to build what will be a better future, where would you begin and how would you go about tackling this issue?
Yeah, I mean, and this responds a bit to the points about non-representative data and about detecting bias in the data set. So I do want to say, I don't know who exactly is in the audience, but to the extent that there are like, young people interested in statistics looking for challenging and important and fascinating statistical problems, I think health inequity is very much one of them, because while it is absolutely the case that we need to collect better data and more representative data, the truth is that in the foreseeable future, we are going to be continuing to work with health data sets which are biased in all kinds of insidious and difficult to detect ways. Just to give an example of this, like sometimes the question of detecting bias is like, oh, like we think there should be this many Black patients with this disease in the data set, and in fact, we only see a tenth of that. That's certainly a smoking gun. But oftentimes the signs are like, considerably subtler. For example, we fit this complex risk predictor to predict a patient's risk of having a disease, and we find that Black patients are being tested for that disease only at higher thresholds. So that's, a much more complex thing to do statistically. You need to fit a risk predictor. You need to try and deal with the people who weren't tested historically. There are all kinds of subtle statistical issues that arise. All this to say, my answer to your question is basically, my hope for the future basically is that we can continue to develop more sophisticated statistical methods that better compensate for the severe lacks in the data that we already have. Because I think that remains a fascinating, open, and important challenge. How do we sort of deal with the fact that the data we have is so flawed, and how do we continue to build on that to try and improve patient care even in spite of that? And I will say that I am optimistic in that regard about the potential of machine learning approaches to increase health equity. And the reason is that the human baseline is so bad. Like, it is very much true that models learned from biased data can be biased, but like human doctors themselves are tremendously biased and inconsistent as well. And so, I am hopeful basically about the potential of machine learning approaches to expose inequity and help correct for it, in spite of the fact that they remain so imperfect, because the baseline world we are comparing to is so bad. And I think the question of how exactly to do that statistically is very much an open and difficult problem.
And we spoke about how sometimes it's the data to kind of go back on ourselves. It's almost like too late to go back on ourselves. So do we have to approach the problem from creating new data with good health equity awareness from today? Or is there a way we can kind of go back and fill in those gaps in the data that we already have?
Like both, very much both, right? Absolutely going forward, we should try to collect better data. Like the All of Us initiative is a great example in this regard. But nor should we just throw out the UK Biobank data, which is 500,000 people with incredibly rich health data collected at an enormous expense, which is incredibly non-representative. And so the question is without throwing out all the data we've already collected, and while trying to do better in future, how do we deal with what we have? Because we are not, health systems are never going to collect perfectly representative data. Bias is too profoundly entrenched in every aspect of the data generation process. It is not just a question of let's get patients to fill out race data on surveys. It's at every single step, they are less represented than they should be. That is never a problem which is going to be perfectly fixed. And so we absolutely need to develop tools to correct for it.
All right, thank you. And just a last question before kind of open the floor for Q&A. I wanted to find out from both of you, Matt and Sara, again, the same question. Going forwards, if we're thinking about the future so that in 2-3 years we're not having the same conversation, what are some of the strategies that we need to start implementing from now? We've heard one of them being representative data from the onset. Are there any other key areas that we need to be focusing on for the future? And if I start with you, Sara.
Sure, yes. So I think, first off, I think something that gives me hope about this whole situation is that when you think about inequity, you think about people from certain geographies or demographies. But if you think about it really, and there's a beautiful picture from a study called Lives on the Line, which is about the London Underground system, and it shows how as you get every underground stop away from Westminster, which is not very far from where we are today, life expectancy decreases by, I don't know, 1 year or 5 years or whatever the increment is. So it's something that affects all of us in one way, shape, or another, either through age, gender, race, rare conditions, what have you. So if it affects all of us, we can all work together to tackle it. So that's where the hope is, and I think the way forward is conversations. So to keep continuing the conversations, and also in a more kind of in terms of artificial intelligence, lowering the barriers to the generation and access of data. And this is at equally relevant at local but also global scales as well. And also, I guess, at the same time, lowering barriers in terms of capacity building. So there's a lot of need for developing good data science or machine learning expertise all around the world. There are some financial implications to that which can be solved, and there are some sort of capacity building which can be solved through knowledge transfer and exchange.
Yeah, I guess I can break it down to the technical front and the societal front in terms of what would help the most. I think on the technical front, actually, making sure, at least in the US, improving the data standardization problem. And the data export problem. I mean, in the US, it's hard for a patient to even get a hold of their own medical records, even from one provider. And so I think we've got a data ownership problem at the start, in addition to a data standards problem. At a societal level, I think there's a lot of education that has to happen in all directions. I think it's not fully understood just how beneficial it is to have, at least in the context of genomics, not in addition to other areas, but fully representative data sets. And for example, there have been examples of mutations that were thought to be disease-causing because they're rare in populations of European ancestry. But as soon as these genomic data sets expand, we realize they're not rare at all. They're not disease-causing. There's plenty of them out there. And so everybody benefits from having a more diverse data set when it comes to fields like genomics.
Mm-hmm. And I think even in other aspects of healthcare, if we went through mental health, women's health, cardiovascular, pulmonary, everyone almost benefits from having more diversity within the space. And I wanted to just open it up to you guys listening. I'm not sure if we have any speakers online as well. Okay, to any questions? So we'll start off with you.
Yeah, so I have one question about to collect the data set. So for example, now we have the UK Biobank. So if we were to collect more data from the ethnic minorities for the data bank, to add to the data bank, to add to the biobank, so what kind of complication will different life experiences influence on adding that data to the biobank? Because people, they live in different era, they might have different exposures of the environment, so that would impact the person's exposome. What kind of impact? How do we try to integrate that data into the biobank?
Any of you can answer.
Yeah, I mean, I can't answer in the context of the UK Biobank, but I can answer in the context of some of the genomic health initiatives in the US. And the way they're structured is such that there's sort of a core set of data being collected at the start, but there's room for growth. So you could add in an expososome or a transcriptome, metabolomes. I mean, these they're not in there yet, but they could be added over time, and they should be added over time too. In terms of the expososome specifically, I think the most complete data set we have in the U.S. is through the Veterans Affairs program, where we have 25 million medical records. It's probably the single biggest lot of medical records in the entire country. And then if you combine that with service history, which is actually not easy to do, but is starting to be done, you start to actually get an expososomic record for all these individuals.
Okay, nice. You with the police seat.
Hi, my name is Kumar. I'm a 2018 Rhodes Scholar. Yeah, thanks very much. Such an interesting discussion. So my question is to do with regulation and sort of, because a lot of the research is done, and then at the sort of point where it's implemented, how do you think regulation has a role to play in terms of bias? And what I'm thinking of is, for instance, if you take tests like 23andMe, for instance, a lot of the tests might be applicable in a specific, ethnic group. But like, where does sort of regulation, and this, of course, is the FDA, the MRHA, and I know the NHS is like particularly, looks at this quite closely, but like, when should we allow a company to sell a specific treatment, diagnostic test, that's specifically tailored for an ethnic group versus not? And so what is those evidence thresholds to do that?
Yeah, in my time in government, I realized that is like the most difficult question to answer. It's really hard. I go back and forth on this one myself. As a sort of an end consumer of the products, what I would really prefer is if they just sort of quantify the level of uncertainty that's in the test, and if possible, personalize the level of uncertainty to me and say, well, gosh, we have no idea what this test means for you. And then I can decide. At the same time, I realize that might not be the best approach for everybody. And so I don't know exactly what the right middle ground is in terms of where you draw the line and say, okay, we'll allow it now. And I guarantee you the FDA doesn't know the right answer either. And I can also guarantee they'll get it wrong.
So,
and I think maybe just to add that, yes, I think there are no solid answers just as yet. And the reason for that is that we've just recently entered into that space where the acknowledgement that there is a need for regulation has happened. So, for example, the European Union is working on their artificial intelligence policy or regulation document, which will be released soon. The UK government has issued their own, artificial intelligence for healthcare regulation or policy. But I think all of those are, works in progress. And if there were to be a solid threshold or cutoff, I don't know how you go about doing, how about sort of determining just one. I think just to add also, in addition to regulation, there's something to be said about better reporting as well. So that's another area that is often overlooked, just generally in terms of medical statistics as well. And an area that in the Center for Statistics at Medicine in Oxford, there's been a lot of work, and that's just about literally, people are fantastic at doing studies, but not nearly as fantastic at reporting what they've done in their studies, and that's as equally important in translating technology into clinical practice. If you want that to happen, then healthcare providers and the middlemen and middle folk from that process, from lab to clinical translation, need to understand what actually happened in that paper. What data sets did they use? What were the strengths and limitations? So standardization of reporting practices is also something that's important, and is an area where we have guidelines like the tripod for artificial intelligence and other ones as well. So there is work ongoing in that area.
Any other questions?
Thank you very much for the talk. I'm a scholar here. I have a question on how do we bring this conversation to countries outside the UK and the US? Essentially, how to tackle inequality or inequity in healthcare collection outside of the UK and the US that was discussed.
I think I will add something just based on my experience of working specifically to solve problems for Black and brown people. One thing that I have found is that when you go to countries, especially in Africa, like a lot of people there don't see it as a big issue because it's the norm to them. Like when I'm speaking to people in South Africa or Nigeria or Ghana, they look at me like, why are you speaking about this? But they do acknowledge that a lot of medical research is coming from Europe. And it's almost like when people are doing the research, when people are implementing what they've found from the research in Africa, they can clearly see that actually this is not the case. Like Matt mentioned about rare diseases, when you actually look at the world, they're actually not rare. But if you look at Europe, it's rare. But my opinion on this is actually engaging people, especially in the continent of Africa, through social media, which is why I asked the social media question earlier. Simply because I was in South Africa, Zambia, Zimbabwe in the summer, And a lot of people there are very connected to the world through social media, but through other forms of like media, they're not really connected. So I think there is opportunity there if you can get it right in terms of like regulation and safely collecting data, to kind of go through that channel to be able to engage them and actually connect the world to say this is a global problem that we have. This is you guys, like you're like at this baseline versus in the UK, this is what the problem we're facing, and connect people through that. But it's just based off lived experience. Whether or not social media is the right thing is still, I'm still working that out. And I'll kind of open it to Emma, Matt, and Sara as well.
Actually, can I mention one? I think another interesting data source is, although this raises privacy concerns, are search engine logs, like through Google or Bing or things like this, which has been used, like by Radia Dabibi and others, to sort of document health needs in Africa. And people have similarly used this to do COVID surveillance, to understand other things. So I think that's another interesting data source that can potentially be used to study health needs in more diverse populations.
It's like even like another anecdote. Whilst I was over in Zimbabwe and South Africa, this even happens in the UK, but I think people don't pay a big eye to it. There's a lot of people would Google or TikTok like eczema treatments. And if you go on TikTok or Google and look at the amount of search results and the amount of views, I think if you search eczema on TikTok, it's like 7 billion views that videos have. And that is 7 billion people who wanted to search for a treatment. But of course, we know like TikTok as a source of information might not be the best source of information. And if you kind of stratify that across the other social media platforms, I'm very sure they probably have like similar results as well. So it's an interesting field. Is there any other questions? Okay, I think we have time for maybe one or two more. So I'll just head over to you.
Thank you for the excellent discussion.
Wait, if you could just use the mic, please.
So I think representative data may need a joint effort from entrepreneurs, or people, and ordinary people, and patients, and also researchers. So my question is, how do we give them incentives to participate in this kind of efforts? For example, for us doing kind of imaging or neuroimaging, we need to persuade people into lying in that machine and for about half an hour and not to move at all. So, and for the cases in China, many kind of data are just in hospitals and are observed by doctors. So when we ask them to can you share data with us, they might refuse and say, okay, so why do I need to share the data with you? So that is a problem. And I suppose for America, maybe the kind of data is kind of a private asset for companies. So how do we give them incentives to participate and share the data and to promote the representation of this data? Thank you.
Mm-hmm. So I think maybe I can say something about data sharing, which in itself is a big concern and a problem. So there are different models for data sharing, right? So there is like the direct two-party arrangement where I volunteer and willingly hand over my data sets to you to do your analysis, and then you can run with it or responsibly report your results to me. There are some obviously considerations around that. So fast forward to one model that has kind of gained traction, particularly through the course of the pandemic because of the need for accelerated, rapid, reproducible evidence generation, is something called federated network analytics. So that is an approach where, just as you said, there can be data partners who are predominantly hospital-based, right, as in China and South Korea and so on. And we did some work with people or data partners in China, South Korea, and other places in the world as well. And the way it seems to work out is that you take out the element or take away the element of data sharing. So instead, the concept that is introduced to that is that of data ownership and partnership. So data partners will never have to share their data with anyone, but instead, if, for example, Malone, you want to, or Matt wants to run a study on question X, then you design your algorithm, you design your scripts around that, and that script and algorithm, or whatever the documentation is, packaged and sent over to yourself in China, or to me in Pakistan, or to you in Brazil, or you in the US, and so on. And then data partners, each of us can run the analysis on our data sets, and we choose to aggregate our results and share our results. And that seems to be an approach that is gaining traction and is one approach of data sharing. And there are other models as well, such as like trusted research environments and so on. But I think, conversations with what works with whom, because everyone's contexts are so different geopolitically as well. Is just as important to keep talking to people and finding out what will work with whom.
Yeah, and I guess just to I think you touched on some really important points. I think data ownership is actually one of the key issues here when it comes to getting data shared, because the hospital might not have no incentive to share the data, but the patients might be all about sharing that data. And so making it clear at the outset that the patients own their data, and when they consent, also say, and you must share my data with researchers if they're trying to do X, Y, or Z at the outset, I think would alleviate some of that problem. So for you go to that hospital, they say, well, our patients have pre-consented and mandated. We have to share it with you if you ask. So I think, making sure that patients have ownership and autonomy of their data is actually really critical to solving that incentive problem.
And I think we're at time, but I want to thank Matt, Sara, and Emma, who joined us from the USA, for the lovely talk that we had today. And I'd also want to thank all of you guys for coming and listening to the talk. I hope you found it useful and have some takeaway notes to take home. So thank you very much.